Grant, I've got the YouTube link waiting to see if it's going live on my phone. So I'll text you if it's not.
Are we live?
We sure are, Paula.
We're good to go.
Perfect. Thank you for joining us, everyone. As some of you may know, secondstreet.org, we are a Canadian think tank. We are a nonprofit, nonpartisan organization, and we support keeping our healthcare system universal and copying policies from better performing universal systems in Europe. As many of you know and have personally experienced, our system is in crisis here in Canada with long wait times, people dying on wait lists. We can certainly do a lot better, and we can do better as our team has seen many countries in Europe do better with their systems. So we're going to talk about policy reforms that we can implement here at home in Canada to help make our system better. So that people aren't suffering in the way that we're seeing right now. So this will be, we are streaming live on X, Facebook, and YouTube. You are invited to participate. You may ask questions by commenting on the video. For those of you on X, you have to comment on the live chat, not as a reply. So click the video and then open the live chat, and you can leave your comments on there. Facebook and YouTube, it's just a simple comment. We are monitoring those, so we'll answer your questions. And specifically, answering your questions will be my colleagues, Bacchus Barua, who is our research director, as well as the president of the organization, Colin Craig.
Okay, well, thank you, Bacchus, or Paula and Bacchus, for joining me on this and for participating. And thank you to everyone who's joining us either live or watching a rerun. The whole point of this is to hear from the public, hear your questions, your thoughts, your concerns about healthcare and what's going on. So I'm just going to say a couple brief words here, and that is that just to kind of touch on what Paula talked about, I think everyone's familiar with the problem. Right across the country, we've got a system in crisis. We've got 6 million Canadians that don't have a family doctor. There's long wait times to finally get a family doctor. And for those that don't, often you end up going to a walk-in clinic for care, and you face a long wait time there very often. Same thing with emergency rooms. We're hearing of, just yesterday I was talking to someone in Winnipeg who had to wait 16 hours with his mother in a emergency room for her healthcare situation. So obviously very unacceptable, long wait times to see a specialist often, long wait times for diagnostic scans to get surgery. Across the board, there's just too many patients falling between the cracks. And that's not acceptable. And that's certainly not to say that there's not good stories that are happening in this country. They certainly do happen. It's great when that happens. But you don't measure the system by those who do get good care. You have to be thinking about everyone and what is going on. And far too often, people are not receiving good care. The real problem, I think, is that for the past 30 years, we've seen Liberal, Conservative, and NDP governments all pretty much do the same thing when it comes to healthcare. Throw a lot of money at the system and hope something works. And I think we can all see how well that's worked out. We have to be looking at the structure of the system to see why is it that we're not getting the kinds of treatment that you can get in other countries, particularly in Europe, where they have public universal healthcare systems and much, much faster wait times. So that is the good news. I told you about the bad news, about kind of the state of the system. The good news is that what we want as Canadians is doable. Canadians want a universal system that covers everyone, where you receive quality treatment and it doesn't take too long to get it. And I guess the other thing is when you walk out of the facility where you're receiving care, you don't want a big bill. I mean, Canadians have been pretty clear on that. So with that in mind, there's lots of countries we can look to, and I'm sure we'll talk about some of those solutions in this chat. Our organization, just as an aside, we've been to Sweden, we've been to France, we've been to Japan, we've documented those systems. You can find them all on our website, secondstreet.org. And that is really the good news, is that what we want is achievable. And like I said, I look forward to taking questions from people.
Great. So just to get started, Colin, there are some exciting health reforms being implemented in Alberta. Do you mind just very briefly telling people what's being implemented in Alberta, and then we can do a deeper dive into what those things mean?
Sure. Yeah, there's three things that Alberta is doing that I think are on the right track. And as a think tank, we've been critical of governments across the country, including Alberta, for some of the things they're doing. We try and praise them when we think they're doing something right. And Alberta is making three fundamental changes that will bring the system closer to European models, like I said, where they have shorter wait times. So the first thing is that they're going to keep the public system, but make it easier for people to pay privately if they want to. So right now in Alberta, generally speaking, if let's say you need back surgery, you might have to wait a year or so. We talked to one patient from just outside of Edmonton. His name's Jeff Grishel. He was living with chronic back pain, and they told him it was going to be about a year. He couldn't handle it. You know, he described having very dark thoughts. And so he just got to a point where he thought, you know what, I got to look for private options here. I can't wait for the public system to get to me. He looked all across the country because there are clinics where you can pay. The only one that did the type of surgery that he needed, that was a private clinic, was in Calgary. And so he thought, this is great. Living just outside of Edmonton, he could drive down the road to Calgary whenever they could get him in. And unfortunately, when he called, they explained to him that they couldn't operate on him. And it's because of some of the bureaucratic rules that were in place that tried to prevent patients from paying in their own province for treatment. So that clinic in Calgary, because of the surgeons, they were just the way that the rules work, they could operate on someone from BC and take their money, or someone from Saskatchewan, but they couldn't do so from Alberta. So Alberta's changing that, so that patients in Alberta will have that choice. They can wait for the public system like they can right now, or if they want to pay privately, instead of having to fly to another province or drive to another country or whatever, they will be able to pay in Alberta. So that's one of the changes. The second one is how they fund healthcare. They're going to change it. So basically what happens is you have governments funding healthcare by giving hospitals a big check each year and saying, good luck. And that doesn't make a lot of sense. No one would do that at the grocery store. You don't walk into a grocery store and say, here's $300, please give me lots of groceries. Everything has a price and you pay accordingly. And so what they do in European countries, and other countries like Europe, or pardon me, Australia, Japan, and many others, is they fund healthcare every time someone actually receives treatment. So a clinic might get, say, 10,000 euros if they complete a knee operation. And so Alberta is going to be switching to that model, and that incentivizes health providers to want to help more patients because then they get more money. It also incentivizes health providers to make sure the money they do receive is spent on expenses that actually help patients, like a doctor's salary, a nurse's, an MRI machine, whatever, those activities that are involved in helping a patient, rather than bureaucracy, paper pushers, bureaucrats, vice presidents, things that don't really help patients. So that's something that they do in Europe. It works quite well. And so Alberta is moving in that direction, generally speaking. And I'm sure Bacchus will get into this more later because he's a real expert on this particular topic. But that's the second thing that Alberta is changing. Certainly makes a lot of sense. And then the third thing has to do with preventative care, making it easier for people to go and get a particular diagnostic scan. So if you have a family history of, let's say, abdominal cancer, right now, what you would have to do if you want to get that scan regularly and find out if you have it, you'd have to go to your family doctor each time, get a requisition, and then, wait for the public system or go and pay privately in Alberta. So the government is saying, no, you don't need to get a doctor's requisition and tie up your doctor's time every time you want to get a scan now. So that move certainly makes sense. I think we need to be thinking more about preventative care and certainly make it easier for people who are trying to be proactive about their health. And with that, the government has said that if someone does go out and pay for a scan and they find something, then the government will pay for the cost of the scan, just to try to encourage people to do this type of thing, because it can ultimately help obviously save government's money. If you catch a problem when it's small before it expands, like in the case of cancer, before it spreads, it's cheaper for governments. It's also good for people, of course, right? Because it increases your probability that you might actually survive cancer. So those are a few of the things that are happening in Alberta. They're positive. And like I said before, there's other things that Alberta needs to do. It's not perfect, but these are 3 positive steps.
Yeah, I'll just jump in and say that, what Alberta is doing is not coming just from an ideological perspective. It's because we're documenting real problems on the ground for a very long time. And as Colin said, it doesn't matter which government's been in power. We've just seen wait times essentially explode over time. I was looking at the last study by the Fraser Institute, and they found that the average wait time in Alberta was 28 weeks in 2019, and it's now 36 weeks on average in 2025. So we've seen a clear ramp up in wait times in the province and indeed across Canada. And at least Alberta is trying to do something different. And they're doing it based on looking at what works well in other countries. And each of these policies are things that are reflections of policies implemented in other countries that share the same universal goal. It's not about stepping away from universal healthcare. It's all about doing universal healthcare better.
Yeah, that's actually perfect, Bacchus, because that leads us into our first question from a viewer. So Grant is asking, out of all the countries Second Street has been to, what is the best performing healthcare system that you have documented?
Well, Colin's been the one who's really done the traveling. I've had my nose in books.
Well,
I'll answer after maybe about the data.
That's a very good question. I think I was really stunned by Japan in particular. Just popping by an emergency room in a hospital in Japan on I think it was a Sunday night, unannounced, just walking around with someone that we had met from Japan. They took us through for an informal tour, and it was like a ghost town. And you just don't see that in Canadian hospitals. The emergency room had it wasn't overflowing with patients. We went into areas where they would do surgery, and you could just see it was all dark because they got the surgery done during the week and everyone went home during the weekend. A very efficient system. And it's a very different structure. It's very welcoming for healthcare providers to enter their market and start providing care, because they can all see how much they're going to receive in terms of payment when they help a patient. So it goes back to what we were just talking about with activity-based funding, how they do it in Europe, where they pay providers a certain amount of money depending on what service they provide to patients. So in Japan, in that system, everyone knows if I open up a clinic and I do knee surgery, well, I can look online and see how much I'm going to receive every time I get that done. So it's a very welcoming system. It doesn't matter if you're for-profit, non-profit, or a government entity, you all get paid the same amount. The compensation rates are transparent. It's a level playing field approach, and it really encourages people to enter the market, to innovate, and so forth. And the second thing about Japan is I think they're wise when it comes to prevention, really thinking about that. And, some of the things they do over there don't necessarily work here, but I think we would be wise to think a little bit more on the prevention side, because a lot of our healthcare budget gets spent on helping people with diseases and health problems that are completely preventable.
Great. So Dr. Anna Kindi is asking, is Alberta increasing doctors per capita and hospital beds per capita?
Yeah, I believe there have been some announcements about investment in spending on doctors. I think it's unclear about how much of that is going towards compensation, how much of that is going towards recruitment. I know there are active recruitment efforts, of course. There have been also lots of announcements about increased hospital beds as well as focusing on long-term care, which I think is another important aspect of it. You know, we have a situation where across provinces, a lot of patients are in hospitals where they don't necessarily need to be getting acute care. They actually need to be getting discharged to getting long term care. But we do, as a country, have one of the lowest ratios of physicians per capita amongst OECD countries. So when kind of going back to the last question that we had about countries that do better, Canada does very, very poorly compared to other developed countries that share the same universal goals of universal healthcare. But when it comes to physicians per capita and hospitals per capita, we're right at the bottom. And it shows, it helps explain why we see the long rationing that we do. Now, this comes with a couple of caveats, though. In terms of doctors per capita, there are two factors. There's a numerator and a denominator. And so your denominator is the number of people. So as your population increases or decreases, your relative availability of doctors also changes. That's one. The second thing with doctors per capita and something to look at is the difference between a family doctor versus specialists. We have a very sort of ironic situation where although news stories and indeed many of Canadians' challenges that are talked about have to do with getting a family doctor, but we actually have more family doctors per capita than most other countries. Where we really lack are specialists per capita. And this goes to really the heart of the system about the fact that we're just not getting people through the system. So a lot of people are going to their family doctor, they're trying to get treatment in hospitals. They have these massive wait times, 36 weeks on average for elective care. And they're just not able to get pushed through the system, sort of like a bottleneck. But the solution about getting doctors, I think, is important to maybe just elaborate a little bit here, is that you can't just hire doctors if they aren't actually doing services and procedures, right? And this comes down to what Colin mentioned about activity-based funding, which has to do with how hospitals are paid, I think, which is really tied into how effective doctors are going to be in the system. Because right now, and maybe it's a good segue, hospitals are essentially paid according to a very old and outdated system called global budgets, which says, hey, this is your general population, this is what we've seen from historical trends. Here's your sort of check for the year that you get to operate under. And with that system, every patient that comes in is seen as a cost, because when a patient comes in, they eat into that system. So when you have that situation, if you hire a doctor, that's actually a cost to a hospital. They're not actually generating revenue for that hospital. If you do switch, however, to what most of these other countries do with activity-based funding, which essentially says hospitals get paid according to the type, complexity, and volume of procedure. That means that every time a patient comes into the hospital gets money to treat that patient. Now, that makes it a situation or an environment within which having a new doctor hired ensures that they're the most productive, because every patient that they treat ensures money comes in and they're able to use that to actually provide care. So that's a long answer to say, yes, I think Alberta, like most other provinces, is investing in trying to get more doctors and retention and more beds. And all of these are great things that are needed and need to strengthen the public healthcare system. But in order for these to be really effective and supercharged, Alberta actually needs to go forward and get activity-based funding implemented sooner rather than later.
Great. So once again, we are live streaming on Facebook, X, and YouTube. Please ask your questions by leaving a comment. On X, it will be the live chat where you can ask your questions. So we have a question from someone just here. Oh, Donna from Winnipeg is asking, but isn't funding the real problem with healthcare? So do we just need more money?
The short answer for that is funding on its own is not the problem. We are I would say one of the more expensive healthcare systems amongst universal healthcare countries. Regardless of which way you measure it, per capita, as a share of GDP, Canada's healthcare system is more expensive than the OECD average, which isn't necessarily a problem as long as your fiscal books are balanced and you don't have great debt, which we do. But the issue becomes when that money is not translating into performance. So when we stack Canada up with other countries that are spending about the same as we do, we're seeing other countries clearly outperform us in terms of the things that we're talking about, in terms of the doctors that they have, the number of beds that they have. And if they don't have, let's say, doctors or beds, then they have invest heavily in MRI and CT scans and capital infrastructure. And absolutely, they have much, much shorter wait times while having similar outcome measures. So really, I think the question about financing is not about the size of the financing, but it's about what are the incentives that are underpinning those dollars, which again kind of goes back to that activity-based funding system. And just trying to understand, like, what do things actually cost in our system? We don't have a market mechanism to understand what prices are. Things are slipping in terms of our understanding of these things. And we don't necessarily have the right incentives in place. So we can have lobbying, slow bureaucracy, all of these things coming up the works, despite the fact that the actual individuals who are involved in providing healthcare are doing the absolute best that they can. And we have great respect for them. But I think shifting the way that things are funded holds the key to ensuring those dollars are actually following patients.
I think maybe I'll just add something there. When we went to Japan, I talked about what it was like going to a hospital, just unannounced. We met with I think he was the executive director of a medical hospital in Tokyo. It was a university hospital. And I started talking to him about wait times, and I casually mentioned that, often in Canada, you'll hear of patients having to wait a year to get their knee done. And he just about fell off his chair. He was shocked at how long the wait times are in this country. And in his hospital, he could get you in. If you need your knee operation done and you're in the public system in Japan, you could come into his hospital and get it probably within a couple of weeks, a month. Like, the difference is stark. You're getting in right away, basically. Whereas here, we know what it's like. You're waiting months and months and months often to see the specialist. Then you might have to wait a while to get your MRI and then to get the surgery. Our wait times are crazy. And I know Bacchus, he could correct me if I'm wrong, but Japan actually spends, when you adjust for age, less on healthcare than we do. So it's just one example of a country where they're getting better bang for their buck. They have a better system with proper incentives in place. And you're ultimately, as a patient, you're getting better healthcare. The French system too, when we were there in particular, it was like, you're getting in right away. Our organization does a report each year called Died on a Waiting List, where we gather government data on patients dying on a waiting list each year, right across the country. And I can remember sitting in a government-run hospital outside of Paris, asking them about this notion, like, did they track it as a problem, whatever. And they were just dumbfounded. It's like, this isn't a problem here. So yeah, it just doesn't happen. They don't have to start thinking about it the way that we do. So yeah, it's this idea that we're just going to throw more money at the system and it's going to get better. I mean, we've tried that for 30 years. And as I said earlier, like, the NDP have tried that, Conservatives, Liberals, they've all had a turn at running provincial governments in this country, many times, in fact. And we can't point to a single example, I would argue, where one of those parties delivered exceptional healthcare consistently, where we could point to that example and say, that province during that time could match up with the best in France or Japan or some of these other peer nations. We've always been trailing behind, as a whole. I'm not saying that no one's ever had a positive experience, but on the whole, we're not competing and doing as well as we could be when it comes to healthcare, and we need to rethink things.
Yeah. So there's a follow-up from Dr. Anakindi, wondering why we don't increase medical school enrollment or increase number of medical schools. 1/3 of doctors in BC are trained outside Canada.
Yeah, so it's a great question. Absolutely, as you'd expect from Dr. Kindi. There have been increases in medical school enrollments, and I believe in Alberta as well. Part of the announcements were to add medical school seats. One of the a couple of the challenges that are associated with that is that they also have to be matching increases in residency programs as well after medical school. for the graduates. You have sometimes strange situations where you can have people studying over here, they don't get a residency position, they go to a different country, and then now their residency doesn't count back in Canada, and then they can't come back and practice over here. So they do have to be done in tandem, which I think one would know. Uh, the reason why we have the sort of school seat numbers and the residencies numbers actually stems from active government efforts to reduce the number of medical seats and residency numbers in the early 1990s. And this is something that folks who are interested can go and look at something called the Bearer-Stoddard report. Um, and that actually led to a plateauing of our physician to population ratios till the late 90s. We sort of started to kind of figure out that we were having challenges with the number of physicians per capita at that time. We started to kind of increase medical school enrollment a little bit during that time to try to graduate doctors, but it takes 6, 8, or more years to get a doctor fully trained. And then we had this strange situation from about the 2010s onwards where some of these newly graduated doctors were not able to actually get employment in hospitals, which is really ironic and unfortunate given the absolute need for these doctors to be practicing. And these are, again, surveys done by I think the Royal Medical Association of Doctors, where they found, I think, between 16 to 18% of newly graduated doctors were not getting employed, which again kind of falls back into the conversation that we were having about hospital payments, right? So one of the reasons why hospitals' budgets can't expand in order to get the doctors in and then pay them to perform those treatments is because of the way the hospitals are currently funded. So I have to sound a little bit like a broken record there, but I do think, again, one of the ways to help that flow of doctors so that we have everything from training to residencies to practice to being compensated to get people treated does depend on also fixing the way that hospitals are funded. But yeah, absolutely, we do need to improve that entire flow from training to actual employment.
I'm going to make a very quick pitch on this. Personally, I think we need to prioritize in the post-secondary sector. If we don't have in a particular province enough nurses or doctors, then we should prioritize expanding the number of those seats in those programs so that we can train more, and cut back on other areas where we don't need as many graduates and we shouldn't be subsidizing as many. So maybe we don't need as many sociology students or some other particular area of study. I don't want to pick on too many different subject areas, but yeah, I think we need to start prioritizing more as a society to say, oh, look, we've got a healthcare crisis in this country. We need more nurses here or whatever. Okay, then let's train more. That certainly makes more sense.
Great. So Taylor Ruby is asking, I'd like to learn more about how a second tier seems to be more prevalent and exposed in Quebec versus more so under the radar / paywall here in BC, for example. So I think by second tier, he means dual system. So why Quebec has a dual system and they don't have that in BC.
Do you want to kick that off, Colin? Now I can take it on if you like.
Yeah, we'll tag team this one.
If needed.
So I think largely it goes back to the 2005 Supreme Court decision, Shaoli versus Quebec, in which case there was a challenge against Quebec's provincial charter that basically restricting a patient from being able to pay violated their charter rights under Quebec's provincial charter. And I'm no lawyer, but hopefully this is a 20,000 foot high enough explanation of how this came down. And the Supreme Court basically ruled in favor of choice, saying that yes, access to a waiting list is not access to healthcare. You cannot just simply put people on waiting lists because you're starting to violate their charter rights while saying to them you cannot pay or have alternatives. And so there was a court decision there, and really from what I understand is that really helped to kind of pave the way to start to open up choice in healthcare. And so what's happening in Quebec is you have surgeons who will kind of flip in and out between the public system, helping patients in the public system and then helping privately. And they're able to do that easier in Quebec. And so they do have, you can pay for a lot of things in Quebec if you are a Quebecer. You don't have to go to another province if you want to get your knee done or your hip done or whatever. You can even get some types of cancer treatment done privately in Quebec. So there's a lot of choice there. And in other provinces, we're just not really in that same spot. Generally speaking, there's a number of complex rules that govern this, but for the most part, yeah, it's challenging for people outside of Quebec to pay in their own province for treatment. Dr. Brian Day out of BC had a court case that was in the courts for well over a decade. It finally got up to the Supreme Court. He was trying to extend those rights that Quebecers earned to the rest of the country, and the Supreme Court ultimately decided to just not hear his case. So by doing so, the Supreme Court actually created two-tier healthcare rights for Quebecers and healthcare rights for people in the rest of the country. So personally, I don't think it makes a lot of sense. I think Bacchus had touched on this earlier, but when you look at all these other countries with universal systems, particularly those in Europe, the ones that perform better than us, they all give patients a choice. You can either use the public system or you can pay privately.
Yeah, great summary, Colin. One caveat I think I'd add is that, I mean, the Quebec ruling was also very specifically about private insurance, as far as I remember. But it did open up, I think, the conversation to just private care more generally in the province, and people understood that not delivering care while denying people a right to get an alternative is really a violation of the charter. Now, one of the things, though, is that court ruling was based on the Quebec Charter of Rights, which is different than the Canadian Charter of Rights, which is why, even though that ruling took place, it didn't automatically apply across Canada, and why you needed to have additional court challenges like we saw in BC and so on and so forth. Now, what happens in a province like BC, though, because I remember the question said something about it being under the radar, and that's correct. And it has to do with the fact that the Canada Health Act is really quite gray in a lot of the definitions about what's medically necessary and not, and so on and so forth. And so, where it happens, let's say, under the radar, it basically just means that these are usually for more minor procedures, usually not requiring an overnight stay, although again, that, has changed a little bit over time, depending on how many hours it is. It would usually be for like orthopedic care and things like that, or for diagnostic care. And diagnostic care is not necessarily provided in a hospital or by a specialist physician or something like that. And so it falls a little bit by the wayside of the definition of the Canada Health Act. But this is not really how things should be operating. You shouldn't have a system where people are trying to find loopholes to figure out a way to deliver care to their patients. What you want to have is a clear and transparent set of rules that everybody understands, but that also is centered on the patient and helping patients, rather than the preservation of some ideological vision of what a system should look like.
Yeah, I should actually add just one point, and that is that, well, why should we have this choice? And that is that, one, it's good for patients because it gives them more choice. You wouldn't have to leave your province. If you imagine that you've got really, really excruciating hip pain or knee pain, and to the point where walking across your room is just like a huge ordeal because it's so painful to do so. Why would we want to force someone in that position to get on an airplane and have to travel somewhere to get healthcare? I mean, that's inhumane. So it gives patients who have the capacity to pay, gives them more choice right in their own province where it's convenient. It's good economically because you can keep those dollars in your province. They get spent at providers where they pay income taxes in your province, which help fund the public healthcare system. But it also helps patients who are in the public system, because every time someone ahead of them in line decides to pay, well, then they leave the public system and everyone else gets to move up a spot in line. So there are benefits to those who are going to pay and those that decide they don't want to pay. So it really does help expand the capacity of healthcare in a particular jurisdiction.
Great. Yeah. So we got some more comments coming in. We have a comment from Ron Laughlin. My wife Beth was told, take her home and let her die with dignity. Unbelievable at the regional hospital. Ron, sorry that your wife was treated that way. Unfortunately, we hear too many stories like this of Canadian patients being abandoned, which is why we do the work that we do, and strive to bring reform to Canada. I hope your wife is better now and found the way to get the treatment that she needed. We also have a question from Peter Oleson. Please comment on centralization of management and delivery of healthcare in BC and Canada.
You want to take that one, Bacchus, or you want me to give a
Sure.
take a
No,
shot?
I can talk a little bit about that. And we might have differing opinions on it. I think that the centralization, decentralization, at least when it comes to things like health authorities, is a little bit of a distraction. We've seen many provinces across Canada go from having many health authorities to one health authority to flipping the script, and I think it usually signifies a lot of kind of shuffling the chairs on the deck board of the Titanic, rather than patching the hole or trying to change direction. That being said, bureaucracy and bureaucratic bloat definitely is an issue, and that probably might get might increase when there's centralization. But we actually don't really have or haven't had for a very long time good data on the cost of bureaucratic bloat and administrative burdens in BC, in Canada until very recently in BC. Just to give you a little, example, according to the Canadian Institute of Health Information, we were apparently spending about $400 million on healthcare administration annually, which is something that a lot of people sort of held up as like, hey, we don't really spend a lot on admin. But the thing is, this calculation was done. It doesn't actually capture the full administrative costs. It's much more related to insurance system. And there was a great analysis by Mark Roseman, who filed a number of freedom of information requests to different health authorities in BC, and found that the true cost was closer to 3.8 billion. So that's 4 million versus 3.8 billion in terms of admin costs. And there was another, excellent work done by, I believe, the CFIB in terms of just the increase in the number of executive physicians and so on and so forth. And these are things that we're just not seeing. Again, these are things that we shouldn't be in a situation where we have to file these FOIs in order to get this information. This should be transparent and upfront. So I would say that rather than just, whether all of it is semi-centralized in a way, I mean, one could say that Alberta is doing that by having these 4 agencies, but it's also decentralizing it by then saying, you have a little bit of a split between the purchaser and the provider. The real question is, what is the incentive structure that ties funding to performance? And is that flow connected clearly? And so that you have less bureaucracy over time.
Okay, so I'm going to move on because the questions are starting to stack up here.
Paul, can I say something about what Ron noted? And it's kind of ties in with what we've been talking about too.
Sure.
It doesn't apply in every case, but we have a website, patientoptions.ca. And as a think tank, day in and day out, we work on health reform, trying to find ideas from other jurisdictions that could help improve treatment. But reform takes a long time. And if you're a patient and you need care right now, you don't have a year or 2 years or 3 years or longer for provincial government to enact reform to the point where it's actually benefiting you. So at patientoptions.ca, you can go on there and learn about things you can do in the public system to maybe try and help your case and move it along, questions you might want to ask and so forth. But then there's also the private side. So maybe if you do need something like a knee operation or hip operation or something else, or you have decided you have to go abroad, there's all kinds of information there. You can find out where you can pay privately in Canada for different things. There's some information about who can help you if you decide you want to go abroad. So people, if you are, dealing with a personal healthcare situation and it's a challenge, you might want to go to that website because you might find it of help.
Yeah, it's very important to get a second opinion. We interviewed a lady named Alison DeCluso, who was also offered MAID. She declined. got a second opinion, did her research, left the country, got the surgery she needed, and she is alive 3 years after the fact and longer than they gave her to live. And she's glowing, thriving, living life, happy. So don't think because mates offered to you that that's your only option. We've seen many people find a way and they thrive. Today a video came up about an 84-year-old lady that was offered MAID. She didn't take it. She just finished hiking a mountain and is doing great. So get a second opinion, go to patientoptions.ca. There are alternatives out there.
The story you did too, Paula, with Regan Johnson, right? This was a guy in BC. He had back problems, worked his way through the public system, had surgery, didn't help him. And they eventually told him, prepare to live the rest of your life in a wheelchair. And he didn't like that. He ended up going to Germany to the ONZ clinic there for back surgery. And he's got his life back. He's riding his motorcycle. He's doing woodworking, cutting up logs in his backyard. Like, I don't think his back is 100% perfect, but he's certainly doing a lot better than rolling around in a wheelchair, which is what the government was going to sentence him to. So there's a lot of it's like you said, Paula, it's good to get a second opinion and explore some of these providers that are outside the country too.
Yeah. So Nora Ava, my apologies for pronouncing that wrong. She is asking, I'm highly supportive of your work. When the new legislation in Alberta when will the new legislation in Alberta appear in the actual changes patients can notice in real life? Example, when will patients be able to see doctors privately? Will it include appointments for health problems not needing surgery?
So I'll say a few words and then jump in, Bacchus, because I know you're following it closely too. The Alberta government has passed the legislation. They have to now pass certain regulations around that issue of choice. My understanding is those regulations are coming in the spring. They're going to have what they call guardrails, which is common in many other jurisdictions where they have this type of choice. The UK, we have a whole post about it on our website, UK, Germany, and others, another country, where they do different things, where they say, okay, doctors, you can work in the public system and work privately, but you have to do so many hours in the public system first. And they have rules like that to make sure there's enough capacity in the public system so that not everyone just flees and does private. I don't think you'd see that anyway, but they have these rules in place, and the Alberta government is figuring out exactly how those are going to be in place. So to your question about when will you notice a difference as a patient, it's hard to say if they bring in the regulations and they come into force right away. You're now kind of shifting the ball over into the private side. How quickly do they respond and start to expand capacity and start to provide even more procedures to patients? So if I was to guess, I would say maybe within a year you'd start to see more options popping up. I could be wrong. I don't know. Bacchus, you're following it closely too. What's your crystal ball telling you on this one?
It's telling me that you're quite right there, Colin. Bill 11 has been passed. That's the one that really talks about things like the flexibly participating physicians, some changes to insurance as well. It doesn't, I don't think, really talks about activity-based funding. So that's something that's still kind of pending. And we'll see how long that takes. But I think that's a tougher change to implement, to get the structure right and things like that. With regards to the guardrails, I think Alberta, like, they're trying to do this right. They're trying to make sure that they're not creating. They understand the possibility that you could have a situation where doctors go from the public system to the private system. That's not what they want. They want to have a healthy, robust public system, and they also want to have a private alternative. And so they're trying to figure out the rules and the guidelines around how that happens. The other country was France, where they have requirements that doctors need to practice for a certain number of hours in the public system before they're allowed to have private practice. But absolutely, I mean, this is going to be dependent on the doctors and whether they want to take this option, because they have to choose to become, I believe Alberta calls them flexibly participating physicians. Generally, it's just called dual practice when folks are generally talking about this. And in the past, when it comes to doctors just opting out, very few doctors have opted out in Alberta. And they were able to do it before, but they chose not to. So it will depend on which doctors choose to be flexibly participating, and exactly what the guidelines are, and how they restrict or help this new sector from evolving to help patients.
Great. So we have a question from Ahmed Ali. Do you guys think we will be able to have a hybrid private/public ever happening in Canada? Heard it is impossible due to Healthcare Act. And actually, I'll combine this with a follow-up from Taylor Ruby as well that's along the same lines. And he said, to that point, private pay within versus needing to leave. The government threatens reduce healthcare funding if we proceed. How does Quebec do this without jeopardizing their funding? So Amin wants to know, can we have this dual system given the Healthcare Act? And the follow-up from Taylor is, how does Quebec do it?
Do you want to take a box?
Sure. So I think a lot of it depends on what we talk about when we talk about a dual public-private system. It can mean very many different things. In some ways, we have one. We have a very similar split in terms of public versus private dollars in healthcare right now, about 70 to 30, very similar to other universal healthcare countries. But that split doesn't hold across different types of healthcare. When it comes to hospitals and physicians, it's more like 90% of it is public, and 10, 20% is private. And then when you go to pharmaceuticals, you have that kind of turned on its head. Most other countries have this 70 to 30 split between public and private right across. The reason why we have this sort of massive amount of public healthcare dollars in the system for hospitals and physicians is absolutely because of the Canada Health Act and the way that it's worded, which essentially creates a binary all or nothing approach when it comes to physician services, particularly those ones that are provided in hospitals, which, if they're deemed medically necessary, then they have to be covered under the public government healthcare plan. And that means that I think that there's probably an over-reliance on that system, and kind of over-involvement of government over there, sometimes at the cost of other areas. Most other countries understand that it's much better to have that mix permeate across. A second kind of caveat over there about public versus private is we do technically have private clinics for family physicians, and hospitals are technically not-for-profit private institutions, although they're funded entirely by budget. But that's the difference between private delivery versus public funding. You have situations like in Quebec and Alberta, kind of coming to that question, and Saskatchewan, where you have a lot of partnerships with private delivery clinics. So these are called charter health facilities in Alberta. In Saskatchewan, actually, these partnerships, which were part of the Saskatchewan Surgical Initiative, were a key component of massively reducing wait times in Saskatchewan between 2010 and 2014, where it's sort of like you have public healthcare dollars, but these small clinics can kind of pop up and provide surgeries to kind of clear out the public list and relieve pressure, but it only works to a certain extent. All of this being said, I think I have a lot of faith in Canadians. I think we are collectively understanding that this system isn't working for patients, and if it's not working for patients, then who is it really for? And we're much more aware of how other countries are doing universal healthcare going forward. And I think leadership really comes from the ground up in a lot of these cases. People like the folks who are tuned in over here, really understanding what's going on, and then advocating that and asking for that from public policy analysts and bureaucrats going forward. So I have a lot of, despite what's going on, I have a lot of optimism just because of how much better we are aware of the reality of how universal healthcare works elsewhere.
Great. So we have a comment here from Ron. An electrolysis machine should be used in every hospital that has an MRI machine to properly identify what is wrong. Not sure if you guys have a comment on that. I know I often hear from people that their MRIs are booked 2 years in advance. So
Mm.
I think even just that is already an issue. All right, so we are nearing the end of our town hall here. Once again, we're streaming on YouTube, Facebook, and X. If you have a question, please leave a comment. So a question just came in actually from Peter Olson on X. Provinces are responsible for providing reasonable access to insured services, but they decide what is reasonable. Please comment on guarantees of care.
I don't think we have anything substantive really in terms of guarantees of care in this country. In other countries, particularly in Europe, they do have guarantees. If they're not providing treatment in a certain amount of time, then patients can go elsewhere. The EU patients covered by the cross-border directive, so you have a choice. You can go to another EU country, pay for treatment, and then get reimbursed by your home country up to what that home country would spend. And if it costs more, well, then you're out of pocket a bit, or like that difference. So they have those types of guarantees. I think they make sense because we are paying into the system as taxpayers. We're promised great health care. We're not getting it. And if you think about what happens if that occurred in the private sector, I mean, we call that fraud. If a company promises you a service, takes your money and doesn't deliver it, well, that's not allowed. And this is what's happening in government healthcare, and it's not accountable. And we do need more things like guarantees, especially when it comes to life-saving treatment. You can't take money from people, promise them that you're going to be there when they need it, and then not be there when they need it. So I think we especially need to be looking at some kind of guarantees for life-saving treatment. I know the Canadian Medical Association has supported that notion as well, that if someone's facing if they're having a need for life-saving treatment and they cannot get it in time in this country, then the government needs to, pay for them to get it elsewhere. I think that's just accountable and ethical myself. I don't know if you have thoughts, Bacchus or Paula, on this one.
Absolutely. I mean, we don't even have guarantees that patients will be informed about how long they have to wait and whether that wait is within clinically reasonable guidelines. I mean, we just did a study on this and found that no province really even has guarantees about providing patients with this basic information. Forget about what happens if they aren't provided with treatment within that time. And yeah, absolutely. That same study, documents how other countries not only do that, but also have guarantees like the cross-border initiative, but also where if the public system can't provide treatment within, let's say, 90 days, then a patient is at liberty to go to a private clinic and be reimbursed by the public system over there. And I think that really incentivizes the public system to do well, to give good care, which is exactly what we want to see. And in the event that it can't, okay, patients don't have to pay the price for it. They get the treatment where they can.
I don't know if maybe we need to, because we're, like you said, Paula, we're going to be wrapping up soon, but maybe just a good news note in all of this is that, we are seeing the system collapse, which is obviously not good news, but we're starting to see some examples in different parts of the country of positive reforms taking place. I don't think they're happening fast enough, but it feels like people are understanding that the status quo cannot continue. We cannot spend another 30 years throwing money at the system and hoping something works out. It is not ethical, especially given what patients are going through. So we're seeing positive reforms in Quebec. We've talked about Alberta, some very positive things happening in Alberta. Some positive things have happened in Ontario in the past too, and I think that's contributed to something Bacchus has talked about many times, is that they have shorter wait times in Ontario compared to the rest of the country. So and they still have a lot of work to do, but some of those reforms they made, I think, are probably contributing to why. So we are seeing these positive things. We're seeing political parties running on health reform now. So definitely some good things happening, and the public, this is probably the best point of everything. When you poll the public, they understand, number one, that throwing money at the system is not going to work. We need reform. And number two, that when you ask them about different reform measures, a majority support those types of changes, allowing choice. As we've talked about, changing how we fund healthcare, so we incentivize output, looking at things like prevention and that. The public is there, and once the public is there, we just need more politicians, I think, listening to the public and understanding that they can run on some of these changes and win. It used to be an issue you couldn't touch politically, but I think that things have changed enough that now people understand that, yeah, it's time to move on finally with health reform, because what is happening in this country for patients, it's just not ethical.
Yeah, so last question goes to Elwood Dodds. Politicians have access to high priority healthcare. If they were forced to use the system of the general public, do you think we would have faster changes?
I'm not sure that they do have access to higher priority healthcare officially. I mean, let's face it, if you're the premier of a province and you get taken into an emergency room, someone's going to figure out that you're a very important person, and you're probably going to get faster treatment. I think that's a given. We do have that element in the healthcare system. If you know people, you have connections, you're going to get treated better. I don't know why some people deny that, but yeah, it's happening. It's like any other industry. It's human nature. You'll lean on your contacts. But as a whole, as a group, I don't, Bacchus, you can correct me if I'm wrong. I don't think there's any special treatment that politicians get. I'm not sure that that's accurate.
There are a couple of things. First, we need to remember that if you're wealthy enough, or unfortunately in desperate medical straits enough, you can travel to a different country.
Yes.
But right now, that wealth is higher than if what you would need in order to get that treatment across the road if it was available. So we've already created a division over there for people who are wealthy enough to get an air ticket, to get a hotel stay, et cetera, and only them are allowed to escape the confines of Canada's healthcare system. And there are many documented cases of politicians who have used that option. There are also documented cases of judges and others, athletes and so on and so forth, who are able to get private care within Canada. I don't know about priority within the system. I think that would probably be, if it exists, would be through kind of back channels and personal connections. But yeah, the CHA does actually have some exemptions for groups related to workers' compensation. And so if you look into data for workers' compensation boards in Canada, and certainly in BC, you'll find that a lot of them actually send patients for private care. Now, what this has done, which is not a bad thing, I mean, they understand that you can get people back to work quicker, particularly in the situation we've created. But what it's done is it's created a rules for thee but not me situation, where these groups, these protected groups, have loopholes and exemptions and all those sorts of things, but the average person is denied that, and I think that's really unfortunate.
All right, so we are at the hour mark now. Colin or Bacchus, do you have any closing comments you'd like to make?
I'd just like to thank everyone who tuned in here. This is really, really remarkable. And I think a real sign of how important we all understand what's going on and how important reform is, and that we are open. We're trying to understand what's going on in the rest of the world. We're trying to get the best data that we can. We're open to changing our minds when we see better data. And ultimately, the patient is really at the center of this. The average Canadian patient, that's who we're working towards trying to build a better healthcare system for.
Yes, and I'll echo what Bacchus just said. Thank you to everyone for joining us and the great questions that came in, and we hope we'll see you the next time we do one of these. And if you haven't, please sign up for our email updates. It's free. You'll get news about healthcare and other activities, the research areas that we're working on. And we'll share information with you in terms of things that you might want to ask a politician or points you might want to raise them about. So again, thank you everyone for joining us today.
Thank you.